Assalamualaikum warahmatullahi wabarakatuh. So today we are going to continue our reading text about the Journal of Meta-Analysis. Kita akan melanjutkan membaca jurnal tentang meta-analisis yang kemarin sudah pernah kita baca pada halaman 1 sampai halaman 5-nya ya. Okay, let's start. Effectiveness of TM-based intervention on BP. Figure 2 and tables 2 and 3 provide forest plots of the main effect for SBP and DBP. Overall, the TM-based intervention significantly reduced daytime SBP, or P is lower than 0.001, and DBP, or P is lower than 0.001. And the SMD for the mean changes for SBP and DBP were minus 0.18 or 95%, CI minus 0.27 to minus 0.10 and 0.18 or 95% CI minus 0.27 to minus 0.09 respectively. However, significant heterogeneity was observed for SBP, or I rank 2 is 73.2%, P is lower than 0.001, and DBP, or I rank 2 is 79.5%. P is lower than 0.001. Next, influence analysis and publication bias. In the present meta-analysis, influence analysis and publication bias were also evaluated. As shown in supplemental figure S2 in the bracket A and figure 3 in the bracket A, kalau di dalam kurung itu kita bacanya in the bracket. No comparison was beyond the lower limit or upper limit. No publication bias was observed for SBP or backtest. P is 0.061 or DBP or backtest. P is 0.317. Supplemental figure S2 in the bracket B and figure 3 in the bracket B. Effectiveness of TM-based intervention on BP in different disease populations. Four main types of chronic disease were reported in the included studies: hypertension, CVD, DM, and obesity. The stratified analysis by different disease revealed that the SMD of SBP was significantly reduced. SMD is minus 0.461, 95%, CI minus 0.758 to minus 0.163. P is 0.002. In those studies that included a population with hypertension, as shown in figure 3 in the bracket A, the SMD of SBP was also reduced in populations with CVD. SMD is minus 0.093, 95%, CI minus 0.181, 2 minus 0.005. P is 0.038, and obesity SMD is minus 0.226, 95%, CI minus 0.446, 2 minus 0.006. P is 0.044, but not for populations with DM. SMD is minus 0.179, 95%, CI minus 0.363 to 0.005. P is 0.056. Similarly, a significant reduction in SMD was also observed with DBP in populations with hypertension. SMD is minus 0.419, 95%, CI minus 0.840 to 0.002. P is 0.055, and CVD SMD minus 0.159, 95%, CI minus 0.259, 2 minus 0.058. P is 0.002, as shown in figure 4 in the bracket A. However, there was no significant difference for SMD of DBP in populations with obesity. P is 0.178, or DM. P is 0.119. The individual risk factors of quality of life, exercise, diet, weight, smoking, and cholesterol level were important secondary outcomes. So, some included studies also gave participants lifestyle advice, as shown in tables 2 and 3, whether participants accepted or rejected their physician's lifestyle advice had no significant effect on the SMD of SBP and DBP. Influence of duration time and method of data delivery on effectiveness of TM-based intervention on BP. In order to obtain a reliable conclusion, the intervention duration time was identified as 6 months or more. Then, subgroup analysis according to the different intervention duration was conducted. As shown in figure 3 in the bracket B and 4 in the bracket B, the SMDs for the mean change of SBP were minus 0.128, 95% CI minus minus 0.239 to 0.018, minus 0.852, 75% CI minus 1.382 to minus 0.321, minus 0.119, 95% CI minus 0.225 to 0.014, and minus 0.239, 95% CI minus 0.377 to minus 0.102 for interventions durations of 6, 9, 12 and more than 12 months, respectively. The SMDs for the mean change of DBP were minus 0.156, 95% CI minus 0.285 to 0.026, minus 0.960, 95% CI minus minus 2.078 to 0.158, minus 0.117, 95% CI minus 0.284 to 0.049, minus 0.176, 95% CI minus 0.336 to minus 0.016 for interventions durations of 6, 9, 12 and more than 12 months, respectively. In addition, some of the included studies delivered the detection data via the device system, whereas Others used just a smartphone or phone calls. The results suggested that there was a significant reduction in SMD of SBP. SMD is minus 0.217, 95% CI minus 0.323 to minus 0.111, and DBP SMD SMD is minus 0.218, 95% CI minus 0.332 to minus 0.104 when the data were sent via a device system as shown in figures 3 in the bracket C and 4 in the bracket C. However, there was no significant difference, or P is 0.287 for DBP, P is 0.044 for SBP when the data were delivered via phone calls. Discussion. Recently, a series RCTs found mixed results regarding the management of chronic disease using various forms of digital medicine technology. Some studies showed improvements in controlling BP in the primary clinical outcomes, but some studies did not show any significant improvements compared to the standard care group. In the present study, the effectiveness of TM-based intervention in reducing the BP of participants with chronic disease was evaluated. We found that TM-based interventions significantly reduce SBP and DBP. This effectiveness was similar to the magnitude of BP reduction reported in a previous meta-analysis. According to this previous report, a reduction in SBP of 3 mm Hg is associated with an 8% reduction in stroke mortality and a 5% reduction in mortality from coronary heart disease. However, the mechanism by which TM monitoring interventions increase the effect of changes in BP in individuals with chronic disease remains unknown, although one study showed that patient activation level was associated with improved health behaviors and clinical outcomes. The investigation regarding an effect intervention to enhance patient activation was limited. However, we also did not find the TM intervention to be effective in reducing BP in DM patients. Actually, control of BP is related to the control of DM, since people with high BP are susceptible to the main comorbidity associated with type 2 DM, arterial hypertension, which increases the rate of complications and hospital admissions. In addition, only about half of telediabetes studies measure BP as an outcome. Because the study participants took on average two antihypertensive medications, which ensured the reliability of our meta-analysis results. Although a significant reduction in BP was observed using TM-based interventions in this meta-analysis, this study still has several limitations. First, the small number of included RCTs or N is 16, and the restricted sample size of individuals means that our findings cannot be applied to a wider population. The majority, which contributed to the inconsistent intervention effects among studies. Moreover, a previous meta-analysis also found that TM intervention showed no significant effect on BP in DM patients. Interestingly, our results showed that the use of TM was associated with improving BP control in patients with CVD and hypertension. With regard to the hypertension participant, poorly controlled hypertension was not an inclusion criterion in many of the included studies. This may have limited the magnitude of BP changes and may explain the borderline significance of our findings. Furthermore, the participants in the included studies generally had well controlled hypertension. Of subjects were female in some studies, and in other studies, most were male, which may limit the accuracy of the results. Second, usual care was added in the intervention group, which may increase the unreliability of results. For example, subjects with diabetes received health coaching and education as part of their standard of care, which could be attributable largely to the effects of the telemonitoring intervention. Third, most population were Caucasian, and the results of this meta-analysis may not apply to other ethnic populations. Fourth, participants in the included studies mainly had a chronic disease where they were usually taking one or more types of medication, which may also influence the results stability. Lastly, most of the studies lasted for 6 months, which may be too short to demonstrate whether chronic disease benefited from BP detection. In conclusion, the aging of the population and the growing number of individuals with chronic disease mean that there is a need for more innovative and effective models of care delivery to improve quality of life. Our results provide evidence that the TM intervention was effective for managing BP in chronic disease populations. We found that TM-based interventions for participants with hypertension and CVD disease may be more efficacious when the duration is 6 months or longer, and when data are delivered via a device system. The TM-based strategy may be a relatively new tool that has the potential to complement medical therapy. For BP control, our results will help the role of TM to be better understood in individuals with multiple chronic conditions. Declaration of conflicting interests. The authors declared no potential conflicts of interest with respect to the research, authorship, and/or publication of this article. Funding. The authors disclosed receipt of the following financial support for the research, authorship, and/or publication of this article. The study was supported by the Key Laboratory of Neuropsychiatric Drug Research of Zhejiang Province, the Natural Science Foundation of Zhejiang Province, and funds from the Health Bureau of Zhejiang Province. That's all for the Journal of Meta-Analysis. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.